So we have a good amount of people joining us.
Right. And I do know that this is Dr. Ritchie is going to probably take an entire hour to lecture, because obviously this is a very hot topic. Adult acquired flatfoot is something that is not uncommon at your practices every day. So, Ann, did you have any other housekeeping things before I go ahead and introduce Dr. Ritchie and we let him take the reins?
Nope. Take it away, Sarah.
All right. Well, all I get to do is talk about our celebrity hairs, which I am happy to do. So we're very, very excited to have Dr. Ritchie with us. The Ritchie Brace has become one of podiatrymeetings.com's newest sponsors for 2022, and we could not be more thrilled about that. I always tell everybody, if you've heard of a tissue and you call it Kleenex, the Ritchie Brace is, the brand is that strong, and patients resonate with that brand. So we're really, really excited to be able to help spread the message and help educate about the use of the Ritchie Brace. I certainly don't have anything educated to say. That's why I leave it up to the expert. But Dr. Ritchie, speaking of the expert, has authored over 50 articles in various foot and ankle medical journals. He is a 2-time recipient of the American Podiatric Medical Association Research Award. He has also received the Richard Schuster Biomechanics Award from the APMA. I apologize. I haven't slept much this week, so my voice is a little raspy. But nevertheless, Dr. Ritchie is also certified by the American Board of Foot and Ankle Surgery. He's a fellow of the American College of Foot and Ankle Surgeons, and he is also a fellow and past president of the American Academy of Podiatric Sports Medicine. So I was telling him earlier, I could go on. We could probably spend the entire hour just talking about his accolades, but I think we would rather just let him get to it. So you have full reign. Thank you so much.
Well, thank you, Sarah, for that kind introduction. And it's a pleasure to be able to offer some information tonight about, as she said, a really hot topic and an intriguing topic, one that is ever changing in terms of our understanding. And what I hope to share with you tonight are some insights that maybe you haven't gained before that'll be of value to you in your clinical practice. So without further ado, we're going to proceed ahead. Just briefly, just to kind of review the history of the Ritchie Brace. Here we go. Some of you may not know it's actually 25 years old. I introduced this back in 1996, and it was a long process of developing different ways to revise our cast correction and fabrication technique to come up with the product that we offer today, which is really proven to be dependable and predictable. I have 20 foot orthotic labs that provide the brace to you, the practitioner. That brace, though, is fabricated in one single facility, but provided by multiple distributors. We also fabricate the brace around the world now in multiple locations. Our two largest outside labs are in Queensland, Australia, and in Vancouver, Canada. We've dispensed well over 100,000 braces since the inception, and that really has given us a proven track record where today we can honestly say our chance of return or having to modify the brace after dispensal is around 5%, which is really less than what most foot orthotic labs get with custom foot orthotics. Our foot orthotic lab distributors you can access on the Ritchie Brace website. You simply go to the physician side of the website and click on distributors. This is just a list of some of those. Feel free to review their own websites and learn about them. And you pick a lab distributor based on everything that lab might offer you, including foot orthotics or other services. We did learn over the years that the predominant pathology that practitioners were ordering a Ritchie brace for was adult acquired flatfoot. And because of that, and because of my own personal interest, I chose this topic for tonight's webinar. We're going to review the pathoanatomy and pathomechanics of adult acquired flatfoot. We're going to talk about how we can examine patients and choose the proper brace for the proper pathology and level of deformity. We're going to tell you how to provide prescription modifications to get a better outcome. And finally, we'll talk about how you can get paid for all this. The adult-acquired flatfoot, by this definition, which I published 20 years ago, is a symptomatic progressive deformity resulting not only from loss of function of the tibialis posterior, but more importantly, loss of integrity of the ligaments that support the joints of the hindfoot, the arch, and the ankle. Yes, we used to call this posterior tibial tendon dysfunction, but for reasons I'm about to show you, the terminology evolved into adult-acquired flatfoot. And this recent systematic review of all the papers relevant to both those topics concluded that posterior tibial tendon dysfunction really limited to the understanding the deformity to a single tendon injury. And it was the recognition that ligaments rupture and are really the primary pathology and the primary challenge in treating it, that assigning the term tibial dysfunction, tibial tendon dysfunction, is really short-sighted. Many of you have seen even a newer proposal for the progressive collapsing foot deformity. The need for this I question, but it's really more for surgical classification and providing subgroups of patients, but again, based on ligamentous disruption. In summary, what we've learned today about the pathomechanics of this disorder is that it almost always starts with a pre-existing flat foot. This shows from research to place increased load, friction, and gliding resistance on the posterior tibial tendon. The pre-existing flat foot unlocks the midfoot joints, creating stress and strain on key ligaments, including the tibialis posterior. And finally, either those ligaments or the tendon rupture, maybe one before the other, that's debated. But it's this sequential rupture of the spring ligament, superficial deltoid, and interosseous talocalcaneal ligaments that really starts the cascade of collapse of the foot. To get better insight in that, you could read one of two publications I've made over the last 15, 20 years. The first in 2007 in Clinics in Podiatric Medicine and Surgery, and more recently, 2 years ago, in Clinics in Podiatric Medicine and Surgery, updating the biomechanics and also focusing on what we're going to talk about tonight, and that's using AFOs to treat the disorder. So these ligaments have to be cut in a cadaver model in order to make the arch collapse, not just the posterior tibial tendon. And since that time, other studies have shown if we do MRI of patients in stage 2 adult-acquired flatfoot, 92% of them already show evidence of spring ligament injury. And some of these patients have a normal posterior tibial tendon. By far, the predominant finding is rupture or attenuation of the spring ligament, followed by the interosseous talocalcaneal ligament. And then we begin to see shifting of skeletal segments as these ligaments rupture. So with the spring ligament, it's a critical restraint to the talonavicular joint. And when it ruptures, we begin to see this classic transverse plane instability across the talonavicular joint, the so-called uncoverage of the head of the talus. We see this clinically as the asymmetry of the deformity shows with significant abduction of the forefoot on the rear foot in this patient's right foot. But the second ligament that ruptures is the superficial deltoid ligament, specifically the tibiocalcaneal section. This is the primary restraint to frontal plane eversion of the calcaneus. And once that ligament ruptures, we see that radical shifting of the rear foot, the eversion of the calcaneus, and the medial subluxation of the tibia and the talus over the calcaneus. As the calcaneus everts radically, it begins to impinge in the sinus tarsi, creating sinus tarsi pain, and finally impingement on the fibular malleolus. That's why many of these patients present not with medial ankle pain, but with what they call ankle pain, or they think they sprained their ankle. They point to the lateral aspect of the foot and the sinus tarsi and the fibular malleolus gutter. We can take MRI images and see the edema that develops around the ligamentous rupture, as well as the osseous impingement of the calcaneus against the fibula. So this ligament insufficiency becomes really important in our clinical decision-making, because once the ligaments rupture, we've learned that foot orthoses no longer are effective. Because foot orthoses rely on ground reaction forces exerted through the plantar surface of the foot only, and through the ligament connection to the tibia, help restore or correct alignment or limit range of motion. Once the ligaments rupture, that effect of the foot plate alone is gone. We used to stage the adult acquired flat foot according to Johnson and Strom's classification, but that was proposed way back in 1987, before we recognized the role of ligaments that come into play. But we still can use part of the classification 1, 2, and 3 to differentiate a mobile flat foot versus a rigid flat foot. And I'm going to take you through this in this brief lecture. The more common classification used today, or the more well-recognized, is the Blumen classification, where they broke down these stages according to ligamentous rupture and level of deformity. And this was helpful in surgical decision-making, not so critical for ankle-foot orthotic decision-making. What is critical is differentiating stage 1, 2, and 3, but not the sub-stages. In order to treat these feet, whether it's surgical or non-surgical, you have to be able to grade the severity of the deformity, determine the level of ligament integrity, and we should also assess muscle function. And while that may sound daunting, it takes less than 10 minutes in the clinic setting. So I'm going to take you through how we do this. The first task is to determine if it's a stage 2 or stage 3 deformity, and whether it's a stage 1 versus stage 2. So here we see the evidence of asymmetry. The left foot is more pronated and the forefoot is more abducted on the left than the right. So we see asymmetry here, meaning the foot has already collapsed or changed on the left side. This is a stage 2. In stage 1, there's no visible change of alignment and therefore no asymmetry. We look for this asymmetry from posterior and anterior. And as I showed you earlier, the more critical change is forefoot abduction, which is clear and asymmetrical on the right side. In this patient, it's not so clear, but as we look closer, we see left side forefoot abduction, more severe than right. And we see an interesting finding of the malleoli. The lateral malleolus is more anteriorly displaced on the patient's left foot, and the talonavicular joint is bulging on the left side and not the right. These are all critical findings after the spring ligament ruptures and the tibia markedly internally rotates. So next, we're going to determine whether it's a flexible versus rigid. We've already determined that patient had a stage 2 deformity. How do we know if it's not stage 3, which is rigid, non-reducible flat foot? Well, the literature isn't real specific on this. Some clinicians do it in a weight-bearing attitude, which I recommend. Some do a non-weight-bearing. But to determine if this flat foot deformity is reducible, we simply place the patient in static stance and we invert the hind foot. If the hind foot can be corrected to neutral compared to relaxed, there's mobility there in the subtalar joint, and this is a stage 2, not a stage 3. If the hind foot cannot be corrected, it's stage 3. We're going to begin with some simple tests to determine if the patient needs an AFO versus a foot orthotic. And again, this is determining if there's ligamentous rupture. The first test for ligament rupture is the single foot heel rise. Now, this test, many people felt, was a test for rupture of the posterior tibial tendon. But we've now learned that there are patients who rupture their posterior tibial tendon who can easily perform a single foot heel rise. And therefore, this test is more indicative of rupture of the spring ligament. In short, a healthy patient when asked to stand on one foot, can easily raise up on their tiptoe with all of their weight on one foot and elevate their heel off the floor at least 4 to 6 inches. Also, the heel is noted to invert as the patient raises up on the ball of the foot. That's a healthy patient. When the posterior tibial tendon ruptures and the spring ligament ruptures, the patient will have difficulty with a heel rise. And even if they do rise, as we see on the right foot compared to left, there's no inversion of the rear foot. A heel rise is a test of midfoot stability. And it really uses the gastroc soleus to initiate the move, not the posterior tibial tendon. A healthy patient, when they do a heel rise, they actually plantar flex the entire foot and ankle across the metatarsal heads. The foot and the foot itself is a rigid, connected lever. It is solid and stable. A patient with a ruptured spring ligament attempting a heel rise has no rigidity across the midfoot joints, and instead of the entire foot plantar flexing on the metatarsal heads, the tibia, the talus, and the calcaneus plantar flex across the mid-tarsal joint. We will see a crease, or what's called a midfoot break, as the patient attempts a heel rise. We will also see this when they walk, because they will not heel rise or heel lift at the end of mid stance in the appropriate sequence. With inability to lift the heel off the ground, we will see this midfoot break. The midfoot break can take various levels of extreme. In this case, the patient's heel never comes off the ground, and the only motion is the tibia and the talus forward across the mid-tarsal joint. Other patients show less obvious midfoot break, but we always compare to the asymptomatic contralateral foot, and in most cases, they can't elevate the affected foot as high off the ground, and the heel will not invert. Another subtle midfoot break. Keep in mind that not all flat feet have a midfoot break, and not all flat feet have a ruptured spring ligament. Here's a patient who has what I call a healthy flat foot. Easily accomplishes the single foot heel rise because all of their ligaments are intact and their posterior tibial tendon is intact. The next test we're going to show you, which is very important for AFO treatment of adult acquired flat foot, is the forefoot supination deformity test. Now, this was first described by a very prominent orthopedic surgeon in Basel, Switzerland, Beat Hintermann, who observed from MRI studies that in every case when a patient of his had ruptured their posterior tibial tendon, that when he supinated their foot, when they were in relaxed stance, the first metatarsal lifted off the ground. He showed, and we can show this in a healthy foot, that when we externally rotate the tibia, the arch of the foot raises, but in a healthy foot, the first metatarsal always stays on the ground. For some reason, he observed when patients rupture their posterior tibial tendon and he externally rotated the tibia, the entire foot inverted off the ground and the first metatarsal rises off the ground. What Hintermann was really showing is evidence of an acquired forefoot supinatus deformity. If you take any patient in stage 2 or stage 3 adult acquired flat foot and supinate their foot, either by inverting the calcaneus or externally rotating the tibia, the first metatarsal, quote, rises off the ground because there's an inverted forefoot to rear foot deformity that suddenly becomes apparent. This is really an acquired supination deformity of the forefoot on the rear foot that we see in any flat foot deformity or any foot that has functioned markedly everted during adult life. The so-called supination linked with pronation mechanism was first described actually way back in 1929 by a famous orthopedist named Steindler. And he described this compensatory torsion of the forefoot in flat-footed individuals. The supinatory position of the forefoot in relation to the posterior is caused by counterpressure of the floor as the heel everse. But as we correct the heel eversion into neutral, the forefoot appears to be in varus, but this is not a true forefoot varus. A forefoot varus would be fixed, non-reducible. A forefoot supinatus, fully reducible. It's an acquired varus deformity, and more appropriately called a supinatus deformity. It's flexible and it's reducible. We can look for this in patients with adult acquired flatfoot in the treatment chair, but it's a little more difficult to orient to the calcaneus and the forefoot. It's better to put the patient in a prone position. And I'm going to show you a very good demonstration here of a patient with stage 2 adult acquired flatfoot. And I want you to appreciate how easy it is to see the deformity in a prone position while you view the patient from behind. You can neutralize the calcaneus, put it in line with the tibia, and look how much flexible, reducible forefoot varus there is here. That reducible forefoot varus must be reduced, it's a forefoot supinatus, when we cast the patient for an AFO. Instead of casting them the way Mert Root advocated back in the 60s, patients with acquired supinatus must have that deformity reduced during the casting process so that we can make an AFO that appropriately contours to what used to be their native foot shape before it collapsed. This is a corrective measure. We're not making an orthotic to the deformity, we're making an orthotic to correct the deformity. And in order to correct the deformity, we correct the cast. We do this when we're casting with plaster or with a STS casting sock for any type of AFO. We use 2 hands and we gently push down on the first ray while supporting the foot in subtalar neutral and loading the mid-tarsal joint. Finally, a newer and very valid test for spring ligament rupture was proposed by Chandra Pasapula, who is an orthopedic surgeon in Great Britain. He's written much about adult acquired flatfoot and, more importantly, the spring ligament. He describes a test where you stabilize the rear foot with one hand, in this case, the clinician's left hand, and you push in a transverse plane across the forefoot. You place your hands across the first metatarsal head, and you simply push the foot lateral. You'll reach an end point of resistance on the healthy foot, and then when you go to the affected foot or the unhealthy foot, in most cases, you'll see a marked difference. The forefoot will go through much greater excursion in the transverse plane compared to the healthy foot. And the reason is they've ruptured their spring ligament. You will suddenly see excessive transverse plane motion across the mid-tarsal joint, which occurs when the spring ligament has ruptured. So we use those tests to come up with treatment decisions. And when we're treating or correcting the adult acquired flatfoot, whether we're correcting it surgically or correcting it with an AFO, we follow certain principles. Many of these you're familiar with and some you may not be. Of course, we try to invert the rear foot out of a valgus position, but as I'm about to show you, and already did show you, we want to evert the forefoot on the rear foot. We want to reduce the talonavicular joint. We want to bring that navicular back over the talus and cover it up again. And by doing so, especially with the AFO brace, we want to keep the tibia more externally rotated over the talus. This is what we're trying to do. It's not as complicated as it looks. We want to pronate the forefoot on the rear foot. We want to supinate the rear foot, and we want to externally rotate the tibia with the talus. This is really what's called the twisted plate model of the human foot, which is getting newer attention in both the surgical literature and certainly has always been in the anatomic literature. And it's become a really strong foundation of much of what I've been researching and teaching. And if you're further interested in that, you can read some of the articles that I published that I mentioned earlier in the lecture. So our treatment goals in treating the adult acquired flatfoot are quite simple. Most important, we want to take the patient out of pain. But long term, we want to restore mobility. And I think when we talk to our patients and tell them why we're going to put them in a brace, we look at them and we say, my goal is to restore your mobility. And I will tell you, that phrase will connect with them more than anything else because they fear a loss of mobility and a complete change in their life and quality of life. And then, of course, we want to prevent progression of the deformity. We will talk to patients and show them that surgery is not the best option initially here. And it doesn't hurt to show them that flatfoot surgery is ambitious, it's challenging, and the recovery is daunting for the patient. We let them know that surgery is still an option down the line, but we've got better things to offer first. We know now from many studies that non-operative treatment of adult-acquired flatfoot has a better than 50% chance of success. These are 8 published studies showing in retrospective and in some cases prospective fashion that a variety of different types of AFO braces treating stage 2 and stage 3 adult-acquired flatfoot has at least a 50% chance of success, meaning avoiding surgery and, even more important, getting rid of their brace after a year. For example, this study by Alvarez et al., published in 2006 on patients with stage 1 and stage 2 adult-acquired flatfoot, using an articulated AFO very similar to the Ritchie brace. 85% of the patients in the study avoided surgery, and they were brace-free after wearing the brace for 1 year. This study, with an impressive follow-up of 8.6 years, showed a 70% success rate of being brace-free and avoiding surgery. This study, conducted and published in the podiatric literature, showed 87% of patients over a 2.5-year observation period avoided surgery and were relatively pain-free. It is therefore valid to tell patients that if they wear their Ritchie brace and stay in it for a year and follow other instructions, there's a 60% chance that they can not only avoid surgery, but they can get rid of their brace and remain pain-free with functional foot orthotic therapy and proper footwear. Essential to this, before I get to the Ritchie brace, is functional rehabilitation. I have learned, and by consulting with esteemed colleagues around the world, that you must put the patients in a rehab program. And the program that most authorities follow was developed and published by Cornelia Kulig out here in California, near me at the University of Southern California. Her study showed that tibialis posterior strengthening, along with top-down strengthening starting at the hip, combined with balance training, was extremely effective in restoring patients' mobility and avoiding surgery. This was her publication back in 2009, showing that the majority of patients in this study avoided surgery by doing rehab, and in this case, only wearing custom foot orthoses. The strengthening program involved transverse plane adduction, which actually strengthens the muscles other than the tibialis posterior. And then she focused on the hip because she found that most of these patients had proximal weakness. And the same hip strengthening exercises you may do in the fitness studio, your 60 and 70-year-old patients can do under supervision with a physical therapist. Strengthening the hips is extremely important to providing proximal stability and making the Ritchie brace work better. Balance training is essential because these patients lose their balance. If you do a Romberg test on any patient with adult-acquired flatfoot, they cannot stand on that foot for more than 1 second. There are several reasons for this, but not to get into that. You can just assure your patient that they need to restore balance with physical therapy. So we have them do the same kind of balance training that an athlete does after an ankle sprain. Yes, they might be 60 and 70 years old and have to modify it, but many of them tell me when my patients went through these programs that the balance training was the most rewarding part of the program to improve their quality of life. Okay, so we went through the treatment goals, and I'm going to get to the number one question I get from practitioners. When do I use a foot orthotic, and when do I use a Ritchie brace? And the answer is, if you know they have ligament disruption, you need to put them in a Ritchie brace. And many of them say, well, how do I determine that? Well, I just showed you with 5 tests. But if I were to pick one test, I would say it's the single foot heel rise. Because in my experience, 25 years using the Ritchie brace, if a patient could not do a single foot heel rise, I usually failed with custom foot orthotic therapy, but I almost always succeeded with the Ritchie brace. So it doesn't hurt to start with a foot orthotic, and many of the shell modifications that we've learned with foot orthotics, we take them right across to the Ritchie brace. We may accommodate the navicular. The Ritchie brace already has a 35 millimeter heel cup. We might put a medial heel skive in. We might put a more rigid rear foot post. We can do all that with a foot orthotic, and we can do all that with a Ritchie brace. But if they can't do a heel rise test, they probably are going to fail with a foot orthotic. Here's a patient that I used all of those corrective measures with a foot orthotic, and pretty impressive correction. In her case, with stage 1 adult acquired flat foot, she became asymptomatic. But in patients who have more severe deformity and cannot perform a single foot heel rise, they get the Ritchie brace. Now, many times their asymptomatic foot looks bad. In this case, very typically, the patient's right foot is the one that hurts. Their right foot is more deformed, but the left foot doesn't look healthy. What do you do about the left foot? My recommendation is to treat the left foot with a foot orthotic. I think that left foot has a chance of going south someday. It may begin to undergo sequential rupture, and I think you need to be proactive and preventive. Secondly, I think a foot orthotic pairs well in shoes with a Ritchie brace in terms of limb length discrepancy, shoe fit, etc. So this is the standard Ritchie brace, which is, as I'm going to show you, really the brace of choice for most patients in stage 2 adult acquired flat foot. It is a custom balanced functional foot orthoses with articulated ankle joints and medial and lateral position limb supports that are secured and adjustable with both anterior and posterior Velcro closures. What is it that makes this brace different than other AFO devices that preceded it? The first is the fact that we advocate and almost require a non-weight-bearing neutral suspension cast. That is a technique not yet well accepted by most orthotists, but as podiatrists, we recognize that provided superior capture of the anatomy, particularly the plantar contour or surface of the foot. It also captures the forefoot to rear foot relationship. As I showed you earlier, balancing forefoot to rear foot deformity has been the cornerstone of podiatric biomechanics, and it's very important in adult acquired flat foot. Neutral suspension cast will lock the mid-tarsal joint to maintain midfoot stability. So this plantar contour is so critical with our foot orthoses, and it's also critical with the Ritchie brace. We embody all of those things that made foot orthotics important: stabilizing the first ray, locking the mid-tarsal joint, and capturing the subtalar joint in a neutral functional position, and in most cases allowing freedom of range of motion across the ankle joint in the sagittal plane. But the use of those limb uprights is really critical. What we're trying to do with these limb uprights is control transverse plane, internal and external rotation of the tibia, which is a dominant motion in the adult acquired flat foot. We're also trying to control frontal plane or medial displacement of the talus. And finally, we want to control abduction of the forefoot. How do we do this? Well, the internal and external rotation of the tibia is the direct way to control internal rotation of the talus. The tibia is attached to the talus. And as the tibia and the talus internally rotate, the forefoot externally rotates or abducts across the talonavicular joint. It is really difficult to control the talonavicular joint with custom foot orthoses. And we've learned we can control it up higher by controlling the tibia. We know that the talus is locked to the tibia and is really part of the leg and not part of the foot. It has no muscular attachments. It moves with the tibia in the transverse and frontal plane. As the tibia internally rotates, so does the talus. And so this marked internal rotation of the tibia carries the talus with it. By contouring to the medial and lateral aspect of the lower leg, we control transverse plane rotation of the tibia and the talus. We know we do. I did a gait study at the gait lab at the University of Massachusetts, Amherst, where we put a patient with posterior tibial, with adult acquired flat foot in the Ritchie brace and compared him walking barefoot. And the biggest change we saw was not in the frontal plane, it was the transverse plane and the tibia. We absolutely were controlling the excessive internal rotation of the tibia itself. But we also want to control this, and that's the medial displacement of the tibia and talus over the calcaneus. We want to push against the tibia medially and keep it back over the top of the calcaneus. This is tricky because this is where sometimes patients don't tolerate the Ritchie brace. Too much pressure here. And I'm going to show you in a few minutes how to solve that. Finally, compared to gauntlet braces, the research shows that we are far better off using articulated AFOs, allowing sagittal plane ankle joint range of motion. These are studies comparing gauntlet braces to articulated AFOs using a gait lab to measure joint motion, and indeed, they had better correction of flat foot deformity with the articulated orthosis than the leather gauntlet. And they felt that allowing sagittal plane motion of the ankle allowed the muscles to work better. It recruited muscle activity to stabilize the foot. We also found from some of these studies that putting a lateral flange or extension laterally on the foot plate helped control forefoot abduction. And I'm going to show you how to do that in a minute. So in short, if I've done my clinical exam and I've graded the level of deformity, here is our recommendation. If they're in stage 2, flexible, reducible adult acquired flat foot, all you need is the standard Ritchie brace. If they have a rigid, non-reducible subtalar joint, stage 3, we use the Ritchie brace with arch suspender. And only in stage 4, where we have an ankle rigidity, subtalar joint rigidity, and the ankle joint is fixed in valgus from deep deltoid ligament rupture, only then do we need the solid gauntlet brace. And we do make a gauntlet brace. So we use the Ritchie brace for stage 2. And in this case, the deformity is reducible. And we put them in the brace, and we know that if we can control the tibial rotation, we're going to control the talonavicular joint. This is a typical case where the patient's placed in motion control running shoes. I would say overall, a motion control running shoe is my preferred shoe for Ritchie brace treatment of adult acquired flat foot. The reason, they have deep heel counters, they have medial posting in the midsole, they have removable insoles to accommodate the brace and the foot orthotic. They do not have to buy a bigger shoe. The Ritchie brace takes up no more room in the shoe than a standard foot orthotic. This is a typical presentation of a patient in running shoes with a Ritchie brace. Now, if they have stage 3 deformity, we want to enhance the control. And we can do this with a patented device, which we have on the Ritchie brace called the Medial arch suspender. This is a more rigid brace. It has double rivets across the ankle joint, which restricts ankle joint range of motion to about 5 degrees. It's not a solid AFO. It is a somewhat restricted ankle joint to provide stability for the arch suspender strap. That arch suspender is reimbursable over and above the average AFO for about another $150 for those people who are into practice management, as we should be. And so the patient has the ability to actually correct their talonavicular joint with the arch suspender. They lift this strap and lock it down, and they can lift the arch and correct the arch across the talonavicular joint to their level of comfort. Now, you would say, well, why don't you just do that on every patient with adult-acquired flatfoot? I would say you don't need to. And this does pose some challenges because some patients tend to slide off the foot plate when we elevate the TN joint. So it can be tricky, and I'm going to show you how to solve that, but it's not my first go-to for stage 2 adult-acquired flatfoot. You can always add it later. The gauntlet is used in this: deep deltoid ligament rupture, severe valgus deformity of the ankle joint, along with a rigid hindfoot. And yes, gauntlets have become very popular in this country, but I think they're reserved for end-stage rigid non-reducible AAF. We have our own version of a gauntlet that incorporates the arch suspender. So we think this has an additional benefit for the arch suspender, and it has additional reimbursement as a result. So we like this gauntlet, but for stage 4. So we also recommend enhancements on the prescription for adult-acquired flatfoot, even starting in stage 2. So at stage 2, as I'm about to show you, we recommend adding a medial heel skive and a lateral flange on the foot plate. For heavier patients, we may want to add a thicker shell. The standard shell for the Ritchie brace is 3.0 millimeter, but a heavy patient may need a 4.0 poly shell. If you put the weight of the patient on the prescription form, we will make that decision for you. You might want to ask for a flat rear foot post. That will stiffen the orthotic foot plate for additional arch stiffening. It's not always necessary. You may want to stiffen it with a crepe arch filler. Again, not always necessary. I'd say for a patient over 250 pounds, yes, you might need to do that. So the medial heel skive, many of you are familiar with. It's a method of flattening the medial side of the heel cup to get a Varus wedge effect on the orthosis. And we can do this with the Ritchie brace. We can invert the heel cup. This is the arch suspender showing how we cut it out, and then we put a lifting strap underneath, and it goes across to the fibula, and we can lift and elevate the talonavicular joint. It's a powerful tool. The patients have to be educated how to adjust it, but once they do, it definitely can be an enhancement for those cases where we're not getting control with a standard Ritchie brace. If the patient is still pronating in the orthotic or Ritchie brace, I'm going to go into this more in troubleshooting. We can add wedging on the foot plate itself from the calcaneus all the way up to the navicular. So instead of just a heel skive, we can do a complete wedge effect of the foot plate to the navicular, but that's something we recommend afterward if we're not getting the control we're looking for. But the real secret to treating the adult-acquired flatfoot that I've learned over the past 25 years is focusing on the transverse plane. The tibial rotation, which I already showed you, but also controlling abduction of the forefoot in the transverse plane. Certainly, a big part of that is the shoe itself, but we can also add a lateral flange to the orthotic foot plate. We can also wedge the foot plate laterally to try to keep the forefoot from slipping laterally. So don't forget the importance of the shoe. Some doctors will have a patient stand up in a brace and they'll immediately see the forefoot abduct and they'll think the brace was made improperly. No, this is not a complete bracing system. You've got to put the patient in the shoe and then evaluate. Because once the shoe is in place, the shoe has added a great component of transverse plane stability that is absolutely essential to the brace outcome. It doesn't have to be an extra depth shoe. It can be a well-made motion control running shoe. But here is the control of the forefoot that's critical in the brace itself, and that's the use of phalanges. Phalanges are really the most misunderstood aspect of foot orthotic therapy and certainly of AFO therapy, at least in my experience lecturing on this topic over many years. A medial flange has been favored as an enhancement for foot orthotic to control pronation. And the idea being that it increases the surface area of contact under the talonavicular joint and the medial arch. That's true. That can't really be argued from that standpoint alone. By making the foot orthotic wider with a medial flange, it makes it stiffer. But it's not tolerated well in adult acquired flat foot simply because the talonavicular joint is subluxing plantarly and often gets irritated by the medial flange. A lateral flange, for reasons unbeknown to me, is commonly used for patients with cavus deformity. But in reality, it prevents the foot from sliding laterally off the orthosis. It wraps around the styloid and the cuboid, and it becomes tricky sometimes to avoid irritation. It is very effective in preventing transverse plane slippage across the mid-tarsal joint, as I'm about to show you. In my opinion, if you order a lateral flange, it should be extended long, almost to the fifth med head, to provide a wall preventing forefoot abduction. A medial flange, while increasing surface area, is also a ramp, and it's a ramp the patient can slip off of. And in adult acquired flat foot, if they tend to slip anyway with abduction, this will make them slip worse. When the shape of the foot plate is sloped, it directs ground reaction forces perpendicular to the slope. And so if we look at this model, the ground reaction forces, the more we slope this, the more it directs the ground reaction forces lateral because they're perpendicular to the foot plate. And in a patient who tends to abduct, that's not a desired outcome. A medial flange will tend to abduct the foot if there's any arch profile whatsoever. If it's a perfect flat arch, I would say yes, go ahead and do a medial flange, but you might want to have the lab accommodate the talonavicular joint anyway with an accommodation or cutout because they tend to blister or get callousing in that area. A safer move is to put a lateral flange because that's a wall which stops lateral displacement of the foot. A medial flange tends to act as a wall to prevent medial displacement or adduction of the foot in cavus deformity. A lateral flange is an enhancement for flat foot, abducted forefoot deformity. Lateral flanges prevent abduction. Medial flanges prevent adduction. They tend to abduct the foot. That's not a good thing with adult acquired flat foot. Don't forget the importance of a well-fitted proper shoe. So in this patient here on her right foot, I want to put a wall along her lateral foot in a corrected subtalar neutral position, and I want to keep that forefoot from abducting. I do that with a lateral flange. So a lateral flange on this orthotic would help prevent what we see here, the forefoot slipping laterally. A medial flange does nothing. So this is the extended lateral flange that goes all the way out to the fifth metatarsal, and I think it's a better way to go, and you can order this on your prescription form, an extended lateral flange. Look at the effectiveness of it in this patient's abducted forefoot. We put that extended flange on, it comes up almost to the head of the fifth metatarsal, and it's a significant correction, even in static stance. If they're still slipping laterally, even though this patient has a lateral flange, we can add what's called a forefoot strap. This is not something I would order ahead of time. I would only order it if your lateral flange is not controlling abduction, because it's an extra step for the patient to strap on before they slip into their shoe. But in this case, it was needed to control the severe abduction with this severe collapsing flat foot. So the final message, we use lateral flanges to control pronation, and we use medial phalanges to control supination. Yes, medial phalanges are ideal for treating cavus feet. And I tell this to my fellow practitioners and they roll their eyes, but I just say this, look at the biomechanics and try it. Because when you put a medial flange on a foot orthotic with a cavus foot, the patients immediately feel more comfortable. A patient like this with a medial arch flange immediately feels more stable because it tends to abduct and pronate their foot and make them less laterally unstable. What about posting the Ritchie brace? Well, if you put a 4-foot post on the Ritchie brace, it tilts the entire brace from the supportive surface. And because we have limb uprights on the brace, we have to keep them aligned to the tibia. So in short, I'm not a big fan of 4-foot posting the Ritchie brace. And in all reality, that's the least area of control, as I've just shown you. If anything, we put sulcus wedges. Now, wedges that start in the forefoot and extend out to the sulcus of the toes are very helpful during the push-off phase or propulsive phase of gait to control either excessive supination or excessive pronation. And so we do encourage the use of sulcus wedging anywhere from 2 to 4 degrees in cases of severe pronation or severe supination with the Ritchie brace. So just real quick, lateral skives and lateral 4-foot sulcus wedges we do in patients with lateral ankle instability. And we also often add a lateral lifting strap and a medial arch flange. So that's the lateral arch suspender for the patient with chronic ankle instability. And we're going to discuss the entire topic of ankle instability, sports medicine, and ankle sprains in my next webinar in about 3 months. Casting for the Ritchie brace is no more difficult than casting for a functional foot orthosis. As I pointed out earlier, we use 2 hands and we reduce the forefoot supination deformity. We still maintain the foot in subtalar neutral, and we hold the mid-tarsal joint locked and fully pronated. We just gently push down on the first metatarsal. This is the slipper cast for a foot orthotic. For a Ritchie brace, we just add 1 additional strip of plaster to go above the malleoli, and then finish off with a slipper cast. No more difficult than casting for a foot orthosis. More popular today is the use of the STS sock, whether it's the ankle sock, as I'm going to show you here. It's a fiberglass casting sock, which is definitely less messy. It's a little faster than plaster, but it tends to capture the 3-dimensional anatomy much better for AFO braces, particularly when we're making solid AFOs and gauntlet braces. So just keep in mind that whether you use the STS sock or the plaster, you must follow the principles I outlined. Neutral suspension, off weight bearing, locked mid-tarsal joint, and a reduced forefoot supination deformity using both hands. The STS cast must be marked at the malleoli as well as the plaster cast so that we know where to put the ankle joint hinge according to the patient's malleoli anatomy, both medial and lateral. So the cast must be marked before you send it to the lab. Nowadays, and what we're encouraging even more, is the use of 3-dimensional digital scanning using an iPad or an iPhone. And in this case, we think we can get a better view of the anatomy from a prone position. So we lay the patient on their tummy, and we get this beautiful image and relationship of the hind foot and the forefoot and the leg. And we take a scan, but we have to position the foot properly, just as we do with a neutral suspension cast. So to take a scan of the foot and ankle, we must have 2 people. We have the assistant operate the scanner, which is usually an iPad, and you, the doctor, will correct the alignment just as you were trained. You will position the foot in subtalar neutral, lock the mid-tarsal joint, and plantar flex the first ray. You use 2 hands, you step to the side, just as I'm doing here, and your assistant will get a beautiful scan of the foot in the proper alignment. If you take a scan of the foot hanging in space and don't have the doctor correct it, look at the level of forefoot supination that will show up and completely distort the shape of the Ritchie brace. However, if you pronate the mid-tarsal joint and plantar flex the first ray, you have a corrected model already that will almost guarantee a more positive patient outcome. Once the positive mold is corrected at our lab and the ankle joints are placed, we mold the material over the positive cast and mold the Ritchie brace as tight as we can to the anatomy. And when we do, the brace fits in the shoe with the same amount of displacement as a custom foot orthotic. And the reason is the heel cup of the brace does not push forward in the shoe any more than a foot orthotic. Unlike a gauntlet brace where the back of the brace extremely displaces inside the shoe, the back of the Ritchie brace is totally open and doesn't affect the heel counter of the shoe and doesn't push the brace forward. We've even had women wear the Ritchie brace in fashionable and semi-fashionable footwear, although this is not recommended for pathologic feet such as the adult acquired flatfoot. We've had people wear the brace in industrial footwear. They simply loosen the upper, since they no longer need the support of the boot. They've got the Ritchie brace to support it. But the brace functions very well inside of most lace-up boots and even some zipper-style boots. This is the preferred presentation with athletic shoes. I'm going to talk about troubleshooting real quick because people asked about this. And the most common issue we get is rubbing of the brace across the medial malleolus. And what this indicates is that the patient's foot is still pronating inside the brace. It wasn't that we made the brace improperly. It's that the brace is pushing on the patient's tibia to try to correct it, and the patient doesn't like it. And so what we're going to try to do is improve the stability of the patient inside of the shoe. So as the foot pronates, the medial malleolus displaces medially. So in order to get the medial malleolus away from this upright, we want to supinate the foot. And so my favorite solution here is to simply put a Corex wedge on the foot plate that wedges the heel and the navicular into Varus. And I can't tell you how many medial malleolus rubs I've completely solved by putting a simple wedge on the foot plate in my clinic setting and not sending the brace back to the lab for any adjustment. Very simple. We don't necessarily put pads on the Ritchie brace when it's rubbing because it just takes up more room. If all else fails, you can modify the brace by spot heating. And we simply apply a little bit of heat here to the medial aspect of the upright, and we gently push down on a tabletop, and I'm going to push down on this medial upright once it's heated, and as I push down, it will go from a straight position to a slightly bowed position. And I hold it there for about a minute while it cools, and what I've done is effectively changed the alignment. Now that's great, but it also has changed the control of the brace. So I would rather do some foot plate modification for pronation before I do this. This is really a last ditch effort. It's not one that I like to jump to right away, but it can be done. And often when it is done, solves the problem. And finally, if the patient is sliding off the brace, you can either order a forefoot strap, or you can ask them to put a lateral flange on the brace. So I'm going to quickly, I'm just going to show you one video. You guys have probably seen this on the website, but this just shows you how effective this brace can be. And this is a patient in stage 2, adult acquired flatfoot. And now we're going to go to stage 2 with the brace. And I mean, look at that correction. We did not need to use a gauntlet. We're allowing full ankle joint range of motion without the challenges of other types of AFO devices. And that's really typical. And there's a guy walking in a boot in the brace with adult acquired flatfoot. And then this is one of my favorites. This is a guy walking with a sports sandal. Now, I never thought you could do this. And when he came in wearing the sandal, I told him he was crazy. But then I watched him walk, and I realized he actually was doing really well. He has no socks. He's wearing a sports sandal. My practice is located in Seal Beach, California, so this is not an unusual attire for a patient. But he's wearing a Ritchie brace and a sports sandal. And the sandal has the same straps across the forefoot to control abduction that any well-fitted shoe would have. So it's not so outrageous to have a woman or a male patient with a proper sandal that has forefoot straps to be very well controlled with a Ritchie brace, okay? I showed this picture earlier of a patient wearing an arch suspender and showing just a profound correction with the arch suspender for stage 3 adult acquired flat foot, both from the front and the rear. I was gonna go through, I think I'm gonna save this for the next webinar, and I might even go into a lot more detail, but I just wanted to kind of brag about the fact that our coding and billing section on our website is really one of the best in the industry. And we have everything there that you need to know about billing, coding, and being Medicare compliant. We have all these documents that I've helped develop along with other consultants to do everything you need to do to get paid properly, not just from Medicare, but by third-party payers. We have our listing of our common billing codes along with the floor and ceiling reimbursement. The reimbursement for the Ritchie brace goes up every year by about $20. We got about a $40 raise last year, and it's the one part of Medicare that goes up, not down, and why more practitioners don't take advantage of DME in general, and battling all these surgical reimbursements when you get paid much more handsomely with non-operative treatment. It's beyond me. So our lab distributors, as well as myself, available for daily consultations on our internet website, can help you with any questions regarding billing or reimbursement. And we can go into this more in subsequent webinars, but I encourage you to go to our website to access these important documents, including videos of how to fit the brace for your patient, which they can watch on their own computer. They can download a PDF of how to fit the brace in their shoes. So there's just a wealth of information there to stay Medicare compliant. So that's basically it. I just want to show you, I've showed you this patient over and over. I treated this patient in 1998. She's one of my first Ritchie brace patients. And she is brace free today. Her feet look terrible, but she has no pain. She wears foot orthoses and good athletic shoes. And so here she is 20 years later, pain free, never had to have surgery, and she walks a mile a day for her fitness and health. She's almost 80 years old now and never had to have surgery and never wore her Ritchie brace more than a year. So that's a fact. And it can be an outcome for many of your patients as well. So thank you very much. I'm happy to take any questions. We can open it up with Sarah or Ann fielding the questions.
Okay, well, that was awesome. Very informative. I mean, like jam-packed with information. So Sarah had a question come in that she responded to, but Sarah, do you want to bring it up just in case there's anything more to add?
It was basically what Dr. Ritchie just showed. He was wanting to see the CPT codes and reimbursement. And obviously I'm pretty aware of what's on your website. So I was able to email or chat with him directly and sent that link.
Oh, okay.
Same link that you just showed on the website. I believe
Oh yeah. Yeah. It was this document.
Yeah, exactly.
Yeah. The codes are listed on the left.
I'll put a link to that PDF in the group, like the chat where everyone can see it.
Okay, that'd be great.
Not a problem. Okay, so this is the opportunity we do have questions. Andy, you want to take that one while I post the link?
Yes. So can you please recommend a common brand motion control running shoe?
Sure. The picture I showed was one of my favorites for women, the Brooks Aerial. I believe that's spelled A-R-I-E-L. And the counterpart of that for men is called the Brooks Beast, which you can remember easily. But those are two of my favorites, but they're certainly not limited. If you go to any of the top brands that you like, whether it's Brooks, New Balance, Asics, and go to their website, they all categorize their shoes based on stability or motion control, and based on those, make specific recommendations.
All right, awesome. So another question we got was, do you recommend standard brace most of the time in clinic for Medicare and non-Medicare payers?
I do, and it really doesn't, it's not so much based on their reimbursement. It's just that brace is so versatile that that's what I use 9 out of 10 times. I mean, the arch suspender literally is maybe 10% of the time. So that is what I use in it, but reimbursement doesn't drive it, because whether it's a gauntlet, a hinged AFO, a solid AFO, they're covered as long as the patient is eligible. So it doesn't matter what the model of the brace is.
All right, and Sarah did drop the link to all the coding information in the chat box, so you can grab that and access it on the website.
I'm also going to put the link in for our archived sponsor webinar series, because this lecture, once it propagates rather on Zoom, we will be able to put it onto our archive page, because that was a question that came in if they could review this lecture later. So I'm going to put the link to our archive sponsor webinar series webpage, so you'll be able to access that at any time. Yeah, and this recording will be up probably this evening, but definitely by midday tomorrow. So you can catch the recording on our webinar archive page, like Sarah said.
And another thing we have, and by no coincidence, Sarah had designed my website and does a great job of keeping it in state-of-the-art form. She has a form on there for any of you to use to consult me, and I respond to your consultation requests usually within hours. And that's on the Contact Us side of the website. And you might, I don't know, show that to them too, Sarah, or if you have an idea.
So one of the other questions that came in is, what are the ideal ICD-10 codes that will correlate best with L1970 for reimbursement for most insurers?
Yeah, that's a great question. I get that all the time, and I had a slide on it, and I think I took it out. But people say, "What's the best code for L1970?" And I say, in all honesty, be sure to use a code that's representative of your real patient. I mean, don't just make up a diagnosis form so that you get paid for L1970. But on our website, we also have a page of recommended ICD-9 codes.
I was going to say, Anne, can you make me the presenter for a moment, and I can share my screen and show Dr. Ritchie's website?
Sure, you can handle it.
Oh, I think I've done this a time or two.
Now, what I did on that page, I've learned from going to Medicare lectures and talking to practitioners, and certainly being in practice myself, that they definitely like 2 codes. And I also learned that you should find a code that describes the disease or injury, and then another code that describes the deformity. So what's the injury? The injury is a ruptured tendon, posterior tibial tendon, and the deformity is flatfoot acquired. There you go, ICD-10 quick codes reference list.
Did it pop up?
Yeah. So let's look at adult acquired flatfoot. I recommended rupture, tendon, foot, and ankle, and also pronation acquired. You can also use adult acquired flatfoot. That has its own codes you see there. A lot of practitioners freak out when they see using a flatfoot code, because we learned years ago, if you used a flatfoot code with foot orthoses and submitted to private insurance payers, they almost always denied it. For some reason, that was like a no-no. I will tell you, Medicare doesn't mind that flatfoot code, but you better put a pathology with it, like either ruptured tendon or ruptured ligament. Okay? So I recommend 2 codes, and nothing wrong with using 3 codes. Okay? So with lateral ankle instability, again, I would use instability of the joint and then isolate the actual injury, which is in this case calcaneofibular ligament. So I'm not finding that codes like that are reasons for denial or appeal, except when you use a foot code. I mean, obviously don't bill a Ritchie brace for hallux valgus with bunion. I wouldn't bill it for plantar fasciitis unless you had other codes such as equinus or global deformity of the foot and ankle. But if you just simply put plantar fasciitis, it's probably going to be a red flag.
And then here was that consultation form that you were discussing earlier on the contact us page. If you just scroll down, you've got a consultation form and it has the information for you and your practice. And then it has HIPAA compliant. So we don't know who the patient is. It's just the initials. So nothing that would be identifying of your patient. So the initials, diagnosis, goal of treatment, specific questions, and clinical findings. So those go directly to Dr. Ritchie. And yeah, like he said, he will respond to those as soon as, you usually get asked to ask me if I've seen it before.
Okay, so another question we have. Excellent lecture, thank you. Do you recommend Defy shoes for Flatfoot?
Gravity Defy, yeah, I've seen those. They're actually pretty stable, but I can't say I've had personal experience with them. I will say I don't think that they have clinical value for what they are purported to be. They're more a shock absorbing shoe to address pathologies that aren't adult acquired flatfoot. I mean, with adult acquired flatfoot, I'm looking for stability. I'm not looking for shock absorption. And so I wouldn't say that shoe, with all it's built up to be, would be of direct benefit, other than the fact it might be a really well-made shoe. So whether it would enhance the outcome, I don't know. I don't have experience with it.
You do have a PDF. I don't know if that's one thing that I'll have to get that up. We do have shoe recommendations for the Ritchie brace, however. Is there not a document?
We did, and I took it off because I need to update it. So that's something we need to work on, Sarah.
Okay, perfect.
Yeah.
I thought so. Well, yeah, just because of my other experience with one of your distributors and knowing those documents. So.
Well, see, a lot of the distributors have them, Sarah.
Exactly. Yeah, and that's so fantastic. Yeah, there are so many sources of this information that, yeah, you've made it very accessible.
Yeah.
All right. So are you holding the foot with one hand or two hands with scanning?
Two hands.
Two hands. Easy peasy. Why can you stop the brace after a year?
That's a great question. Yeah, the scanning picture, Sarah, was on my, we might have to go the screen back to me. Oh, there. Well, you can.
Sort of.
Yeah, there you go, right? You can sort of see me.
I can take you back to your slides. We can make you presenter again so that you can show your slides. So let me get out of here. I'm going to stop share. All right. Andy, you want to make, I don't know, since I'm not host, I don't know if I can make people.
Yeah, Dr. Ritchie, you're still co-host, so you should be able to share your screen now.
Oh, perfect.
Okay. Okay, so to answer the question though, and that's a great question. People always ask me to say, how can a patient be brace free, after a year? Well, the bottom line is, and I suspected this before, but I've seen more recent research, ligaments heal. Let's look at an athlete with a ruptured anterior talofibular ligament, and they're back playing sport, 6 to 8 weeks later. They had an anterior drawer sign and it goes away. We know the lateral ankle ligaments heal. We're now seeing evidence the spring ligament can heal. There are MRI studies, there's case studies in the literature showing the spring ligament will heal with appropriate bracing. So where's that picture? There it is. Okay. So there I am holding, I guess I'm not holding the foot with two hands. I'm pulling with my right index finger. I'm pushing up on the 5th met, pushing down on the 1st met. pushing up on the fifth, down on the first. And the reason I'm standing where I'm standing is you got to get out of the way of the scan. The person taking the scan has to be able to get a posterior view of the foot. And the only way they can do that is if you're out of the way. Okay. That's what the scan looks like when they're done. Okay. So, yeah, I mean, I think ligaments heal. I think things stabilize in the foot. And I will tell you, the foot doesn't look better after a year. It's not corrected like it is surgically. That patient I showed you 20 years later, her foot looked horrible, but that didn't bother her and it didn't bother me because she was fully ambulatory. She was relatively pain-free. She was walking a mile a day. And her foot was pain-free because the ligaments were stable and the foot wasn't hypermobile anymore. That's what I think happens. But you can't dispute, 8 studies, which I showed you on there, from different institutions with different types of braces. So I don't think it's a pipe dream. I think it's an absolute fact.
Okay, so next, where can a patient find shoe gear with either very small or very large feet?
I think you have to go to your specialty shoe store in your community. I do know that New Balance used to have the largest range of shoe sizes for children and adults for excessively small. I don't know if they still do, but I don't know how to answer that question. I don't get that very often simply because the Ritchie brace in most cases is for adults. And, so we're not dealing with really small feet. So I may have to defer to that. I'm not sure how to answer that other than perhaps New Balance, or the internet is always a great source of information.
Sarah, here's one for you.
Oh, I know.
Can you upload clinical pictures to the contact us section for consultation?
I'm legitimately fixing the form right now to do that.
So the answer is you will be able to shortly.
Right. So I'm adding a section on that form that says upload relevant images. However, please do not upload anything that could violate patient privacy or HIPAA regulations. So when those come through, Dr. Ritchie, a lot of times they're tricky to see. You can only really see them on the back end of the website. So when I see, obviously, I see those come through as a backup, I'll be able to send those to you. But so yes, the answer is yes.
Nice.
So we're talking about stuff like this, right?
Like being able to upload JPEGs of if they have x-rays or anything of their patient condition. Mm-hmm.
Okay.
Cool. I need a bit of clarification on this. A lateral flange is for cavus foot and medial for... Sarah, you want to take this one? It's a lot of medical words.
No, I know. Okay, so what you just said is the exact opposite of what I want to teach. But what you just said is the way we were all taught. We were all taught to use a medial flange for flatfoot and a lateral flange for cavus feet.
Yeah, so that's what it says. A lateral flange for cavus foot and medial for adult acquired flatfoot in stage 3. And the lateral flange prevents a calcaneus from sliding laterally.
That's all incorrect.
Can't we just say heel? Do we have to say calcaneus?
So, and I don't blame that question because that's the way that person and I myself was trained, but all of that is wrong. So the bottom line is, I'm going to go into cavus feet and lateral ankle instability in my next lecture, but I can tell you that for flat feet, and particularly the adult acquired flat foot, you want to use a lateral flange. You want to use a lateral flange because that prevents forefoot abduction. People ask me, why don't you use a medial and a lateral? And I say, that's fine. However, you don't really need the medial with adult acquired flat foot. The only reason you're going to put a medial flange is try to increase the surface area. The Ritchie brace has a 35 millimeter heel cup. It's already a very wide foot plate. Flanging medially only tends to invoke abduction of the foot, which you don't want. It also tends to irritate the talonavicular joint, which you don't want. So a lot of bad things happen with a medial flange and a lot of good things happen with a lateral flange.
All right. And finally, do you incorporate first ray cutouts in your brace design?
We can. We will do that. We can do whatever you want with your foot orthotic prescription. That's a great question, because whoever asked that knows that a first ray cutout is a great way to enhance stability of the first ray with flat foot deformity. It's a great way to deal with a hypermobile first ray. I think if you take a good cast and you push down on that first ray, you don't need to do a cutout on the foot plate, because the foot plate is going to be shaped in a way that the first ray is allowed to come as close to the ground as it can. You don't need to do a cutout. But I always say you can do a cutout in your clinic setting. Hopefully you have a grinding wheel there. You can always do it afterward if you think you need to. I rarely do it. And I just frankly don't think you need to do it as long as you do a proper cast.
All right, good. Well, it looks like that's all the questions that we have typed into the Q&A or chat right now. Jose Rodriguez did post in the chat that New Balance does have up to 17 long and 6E wide, so that is helpful information. If anybody has any other questions, now's the time. You can type them into the chat or the Q&A and we'll get them answered. Otherwise, we will post this recording on our website before tomorrow midday. And I mean, thank you guys for your attention. We had a bunch of really great questions on this webinar, a bunch of active participants. So thank you very much for all of your attention and your time. And Dr. Ritchie, thank you for spending the time with us and giving us such an informative, information-packed webinar.
My pleasure.
Yeah, I did update that form, so I have it so you can upload at least 3 files, so 3 JPEGs to help kind of pictures worth 1,000 words, right?
All right. There is one more question that just popped up, and I don't know how to pronounce this. Could you talk about, is it Skive?
Yep.
Yeah. So that's really just a simple technique to create a Varus wedge in the heel cup of the orthosis. That's all it does. The lab skives plaster away from the model, and it creates a wedge effect under the calcaneus. And it's been very popular in podiatry for 20 years or more. And we found it to be a nice enhancement in the Ritchie brace for adult acquired flatfoot. So it's one of those things. It's on our prescription form. You just check the box if you want a heel skive. And as I showed in my lecture, I would say it's a routine enhancement on the prescription form, as well as a lateral flange.
Dr. Ritchie, I have one quick question, just because I think this is important. I think it's important, but I don't know if it would. I don't know if it will necessarily be a question for those that are on, because it could be that everyone who is on is prescribing AFOs. But for those who may be referring them out, what do you tell physicians who are currently referring AFOs out of their practice?
You're missing out on a golden opportunity to provide a treatment that would make a patient indebted to you for the rest of their life. There's nothing more gratifying than having a positive outcome with the Ritchie brace. I mean, I'm a foot and ankle surgeon. I've done as much or more flat foot surgery than most people. I never got the gratitude I got from any surgery, even with a perfect result, than I got from a Ritchie brace. Secondly, if you're the one prescribing the brace and fitting it and following through, you get the credit for that. Otherwise, the guy down the street that you farmed it out to gets all the credit. And finally, the income. You're just referred out $900 in income to someone down the street. Why would you do that? It's I don't want to say it's easy income, but it's a kind of a no-brainer. And compared to a triple arthrodesis, a Ritchie brace pays more. Why would you not do that? So
I guess the question is, why would you not do that? What is the main reason why DPMs may be apprehensive to bring this type of therapy into their practice?
Having talked to them, I've learned 2 things. The first is they think it looks too complicated. They somehow think the casting is different or harder than foot orthotics, and of course it isn't. And secondly, they're afraid they won't get paid. I'm still surprised how many DPMs don't have a DEMA post provider number, and so they farm everything out. And again, they think it's a big hassle to get one, and it's not. It's a, you know, it's an application, but it takes at the most a half hour to fill out. And once you get it, you can bill for walking boots, you can bill for crutches, you can bill for, you know, dressings, you can bill for all the stuff that you're now giving up. So there's, you know, despite these perceived barriers, they're really not real barriers. So to me, it's just, it's a lost opportunity.
Sure. Yeah, I just wanted to get those questions across because I just wasn't sure if there's anybody online who's been on the fence, or maybe they did AFOs years ago and then they've let it go and, you know, they're not really sure why.
Yeah, I think we'll go into that more with the next webinar because I kind of skipped over the reimbursement. So I'm glad you brought that up because those are issues I'd be happy to discuss and kind of unveil.
Awesome.
There's one more question that popped in. What's the difference between a heel skive, or incorporating a calcaneal varus post?
Oh, there's a big difference. I'm glad they asked that question. A heel skive is a shape to the heel cup of the orthotic. It's a shape that contours directly to the heel bone, which Sarah has called the calcaneus. Okay? A varus post is on the outside of the orthotic. It's on the external surface. And it tilts the entire orthotic foot plate on the supportive surface. It doesn't necessarily provide a contact or a change of contour to the heel bone itself. So it's more removed from the heel bone. They both have an influence on the foot, for sure. They both tend to have an inversion influence on the foot, but they do it in a different way. And with the Ritchie brace, you can do both. You can put a rear foot post on a brace and you can put a heel skive. And in most cases, I say, yes, do both.
Okay, good. Thank you again, everyone, for all your awesome questions. Thank you for challenging my vocabulary skills and pronunciation efforts. And yeah, if you guys want us to connect you with Dr. Ritchie directly, you can, of course, go to his website and fill out that contact us form. Or you can always email us directly at beheard@podiatrymeetings.com and we can connect you to Dr. Ritchie. And yeah, that's all I have. Sarah, Dr. Ritchie, do you guys have anything to add?
Nope, just can you see my screen with Dr. Ritchie's digital booth?
Yes.
All right, so yep, so make sure you do. We've got our online marketplace, goes on year round. So there's obviously fantastic. These are all the same tools that are on Dr. Ritchie's website. So, but the booth is just fun, right? So if you are dying to see him in a trade show atmosphere, you can see our virtual booth. Otherwise, you can just go to ritchiebrace.com, but there are also tools on his sponsor webpage at podiatrymeetings.com, which of course we have an entire marketplace of our sponsors. So there's a plethora of information that you can get from all of our wonderful sponsors here and those that support us. So thank you again.
All right, Dr. Ritchie, thank you very much for your time. We greatly appreciate it. You're awesome.
You're welcome. Thank you.
All right. Good night, everybody. Thanks so much. Again, this will be posted later and have a fantastic evening.
Okay, see you in Austin. Bye.